Muy bien, creo que podemos comenzar. I think we can start. Actually, today is our English language session, so welcome. This is our webinar, our NEMUS webinar series 35, number 35, our 35th session. It's going to be focused on selected PrEP-related content and discussions that took place at CROI 2018. So, as you know, CROI 2018 took place in Boston from the 4th to the 7th of March. And as usual, it offered a space for engaged discussions concerning the basic science, treatment, and prevention of HIV. At a time when several studies on new forms and agents of PrEP are ongoing, many countries are also designing or implementing plans to scale up oral PrEP, as recommended by WHO. Significant knowledge is being obtained from such efforts, which will influence, no doubt, both global policy and new research. Finally, CROI 2018 was a setting where many examples of such knowledge were shared and discussed. So in today's, in English, and tomorrow's webinar sessions, we are going to cover some selected PrEP-related content and discussions. In particular, we thought it would be very useful to focus on a symposium that in a way summarized all these dilemmas, promises, expectations, and challenges. This symposium was called PrEP Works, Now What? It included 4 presentations, one called The Intersection of PrEP and STIs by Julia Schillinger, second one on the impact of PrEP on HIV incidence by Roel Coutinho, a third one on 5 controversies in PrEP scale-up by Linda Gale Becker, and finally one called Taking the Leap in PrEP scale-up, a good type of challenge by Nelly Mugo. Those abstracts are available at the CROI site, and it's going to be shown in the presentations right now. So we are grateful to Dr. Kelly Gaconda and Dr. Juan Vicente Guanira, who are both part of our IMPREP team here in Peru, the team of the IMPREP PrEP demonstration project that takes place in Brazil, Mexico, and Peru. And they prepared this session, and Dr. Conda is speaking today, Dr. Guanira is speaking tomorrow in Spanish. So I will just briefly introduce Dr. Conda. She's an assistant professor at UCLA, an associate and research associate at UPCH at our University School of Public Health. She has lived in Lima since 2004 and has worked in HIV and STI prevention ever since. She has a PhD in epidemiology from Hopkins with a specialty in infectious diseases. She's conducting several studies, including in PrEP on the implementation of PrEP within the health system in Peru. Dr. Guanira is an MD from Cayetano Heredia and got his MPH from the University of Washington at Seattle. He has more than 15 years of experience in clinical research, particularly HIV prevention. Was one of the investigators of the IPREX sites in Peru. The very first study demonstrating the efficacy of PrEP among MSM. And he's part of the team. He's been involved in NEMUS since the beginning, and he's also part of the IMPREP study team here in Peru. He's the executive director of Inmensa as well. So I'm pleased to leave Dr. Conda with you. Please, Kelika. Thank you.
Good morning, everybody. I'm going to give the presentation that Juan and I have put together based on the 4 presentations from CROI. And we're just going to go through all of these 4 presentations and try to get through everything in an hour. It's a lot of information. This was a 2-hour symposium, so we've tried to compress and summarize what was said. As Carlos mentioned, these were the 4 presentations, and I'm just going to go through them one by one. The first one is about the intersection of PrEP and STIs by Julia Schillinger from the US CDC. And so from the outset, there have always been concerns about behavioral disinhibition and that the increase of PrEP use would lead to also the increase of STIs, all of this offsetting the benefits of PrEP. There have been national increases in STIs among men and very little increase among women. And one of the hypotheses behind this increase is that the increase is related to PrEP use. PrEP use is predominantly among men, so potentially these 2 things are linked. So the first thing is, what are the drivers of bacterial STI diagnosis? Part of that is increased detection, increased screening, increased sensitivity, increased number of anatomical sites being screened, and increases in testing opportunities. These can also be increased by transmission, so increases in condomless sex, increased number of sex partners, or duration of untreated infection. When it comes to detection, MSM have a lot more screening opportunities. So the CDC recommends at least annual screening for gonorrhea at all 3 anatomical sites. Chlamydia screening is recommended at 2 anatomical sites. It's not recommended pharyngally. And serology for syphilis. For heterosexuals, this is not true. So screening for gonorrhea and chlamydia for adults at increased risk is recommended, and syphilis screening for pregnant women. However, no extragenital screening is recommended, even if oral or anal sex are reported. So one of the main messages of this talk was that PrEP is not a drug, it is a sexual health program. PrEP is offered to people at high risk of HIV infection, and evidence of high risk includes a recent bacterial STI infection. STI and HIV counseling and monitoring are part of the implementation of PrEP. PrEP is always given with counseling around consistent condom use, and HIV and STI testing and symptom monitoring every 3 months are part of the program. Screening is usually done every 6 months. Some places this is done every 3 months. And basically, Dr. Schillinger's point about this was that how often screening occurs should relate to how many STIs you are actually picking up. And PrEP uptake in the US has been pretty high, especially in the last couple of years. So in 2015 and 16, over 30,000 people each year were beginning PrEP. And almost all of this is among men. So this is the difference between the rates of chlamydia, syphilis, and gonorrhea from 2007 to 2016 compared to HIV diagnosis. So bacterial STIs are increasing while HIV is decreasing or maintaining steady, although it does seem to be decreasing. STI rates among men were increasing way before 2012, which is when PrEP was actually introduced. So the increases in STIs are not necessarily occurring at the same time as the introduction of PrEP. And then there are also a ton of other changes. So she talks about, the introduction of iPhones, the introduction of Grindr, the expansion from the ACA of including young adults on their parents' insurance, the results from HPTN 052, and then the introduction of PrEP and the additional expansion of the ACA later on. So all of these things are occurring. It's not just the introduction of PrEP that's necessarily leading to the increases in STIs. And again, the increases in STIs were starting before the introduction of PrEP in 2012. So then there's also a lot of increases in STI detection. So it's not just increased availability of testing, but also the huge change in the implementation of NATS testing, which greatly improve screening. And also, one of our points was that it's not just that NATS testing became available and therefore it's used, but it also means that it's because it can be done by self-collected swabs, there's also increased provider adherence to the testing guidelines, which also increases detection. So this is just showing that the increases in chlamydia and gonorrhea NATS testing was up by 160 and 180% during this time period. And also that male chlamydia and gonorrhea infections by anatomic site have been increasing. So this is the darker bars show how much extragenital chlamydia and gonorrhea were found, just showing that these extra sites that are being screened really do increase the number of infections that are being diagnosed. So STI screening is part of PrEP programs, and again, PrEP programs are primarily for people who are at very high risk. So if you increase STI screening because of PrEP, it logically follows that STI diagnosis will increase. And then also because you are screening these people and then treating them, because these are curable bacterial infections, you actually return this whole group to the susceptible pool. So it's not just that you're picking up infection, you're treating it, and then all of those people who are treated can then be reinfected. So it's not that necessarily there's a huge increase in STIs among PrEP users. So in open label trials and implementation studies, there are some kind of mixed results, and there is some description of risk compensation, but it's not necessarily just this individual level thing. It's more that there are community level differences. So from 2005 to 2014, condomless anal sex has been increasing no matter what. And if you exclude people who are on PrEP, the trends are still there. There's also been an increase in the number of sex partners reported and evidence of more syphilis infection in individuals without HIV infection, also just showing an increased risk among people who are not infected with HIV. So in summary, we do see an increase in STI diagnosis and in sexual risk behavior. Both of these, however, predate the introduction of PrEP in the United States and the results of HPTN 052. And most of it is based on community level risk compensation, not individual level risk compensation among PrEP users. That may also be occurring, but the community level changes are really what's more salient. And there's also a huge increase in the detection, which is a likely explanation of part of what's being seen. So NATS testing and extragenital testing have both greatly increased STI screening, therefore diagnosis, and there's also some increase in transmission because of the sexual risk behavior changes. So PrEP functions, because of the way it's implemented, as an STI control intervention. And it's critical for high-risk individuals. And it works to bring high-risk individuals into testing centers to be screened. So, in the context of PrEP and what can be done to deal with high risk, part of this is that PrEP works as an intervention to provide sexual health to high-risk individuals, also providing them with something that will prevent HIV infection. So she does highlight the need to better understand PrEP use and to use standardized measures of community level risk, and also do a better job of understanding the barriers to PrEP and to work to improve partner notification, which would help with ongoing transmission of STIs and also help with, once people are returned to the susceptible pool, if you also treat their partners, that would help to break those links. And also the need to work to promote condom use in conjunction with PrEP and not to treat it as one or the other. And to promote PrEP as a comprehensive sexual health intervention. There are lots of people who cycle on and off of PrEP. So if you were on PrEP at some point, that's probably an indication that you require more STI screening, but that should be documented. So in sum, basically, her main point was that PrEP is an important sexual health intervention for high-risk people, and it does not seem like PrEP in and of itself increases risk for STIs, but that the increased risk for STIs that's being seen is real and requires attention, but that PrEP can actually be part of the solution and not necessarily considered part of the problem. Okay, I'm going to move on to the next presentation, which is the impact of PrEP on HIV incidence.
Kelika, just one question. If you go back one slide. Yeah, I think it's a very interesting set of points what the author presented in this case. No, the idea of PrEP as a sexual health intervention. Well, it's not exactly PrEP. Perhaps it's the implementation of PrEP implies sort of a periodic medical checkup situation that favors sort of a preventive sexual health program in and of itself, so which is a very interesting concept. We had already sort of realized that was the case, but I mean, it's acquiring a new perspective in, I mean, just because of the use of language in this case. Now, also the issue of community risk compensation rather than individual health risk compensation is also very interesting, a new concept in this case. Probably something that is not so clear is the issue of yeah, probably it's a key issue and is never sufficiently addressed with regard to PrEP, is the fact that it's recommended for use together with condoms. I mean, that's the formal recommendation, but in practice we know that it's not happening. So I mean, that duality, no, in theory it goes with condoms. In practice, I mean, we all know it doesn't. So I think that deserves some specific discussion. And finally, a question: was there any mention on the use of antibiotics for prophylaxis?
For prophylaxis for STI infection? No,
Yeah.
there wasn't.
Okay. I mean, there were just comments. I don't know. Very interesting presentation anyway. Move ahead. Go ahead.
Okay. So I will continue to the next presentation, which is by Dr. Coutinho, and really looks at different modeling studies around the potential for the impact of PrEP on HIV incidence, because this is something that really is still very much a question as to what PrEP in real life circumstances will do in terms of the reduction or not of HIV incidence, and how that will be different depending on the epidemic situation of the context. So, sorry, there are a couple of typos there. Effectiveness of PrEP to reduce HIV incidence. This is just a slide of the different PrEP trials and the relationship of drug detection in the active arm with risk reduction. And as has been shown time and time again, adherence is key for effectiveness of PrEP. PrEP really only works if you actually take it. And there is risk reduction seen among men of sex with men who are on PrEP. So PrEP does work, but you do need to actually take it for it to function. So for the most part, the PrEP recommendations that are existent are to provide PrEP to groups at substantial risk. So the ideas are to lower the incidence in high-risk group by improving access. And so, this is not, the point here was also that PrEP means that you have to be HIV tested, you have to come in for STI screening. So you're bringing in a high-risk group to the health system. And that should lower incidence in and of itself. And then the idea is also that if you are giving PrEP to people who are at high risk, then you should also diminish onward transmission from PrEP users to their partners, be it sexual partners or needle sharing partners, thereby decreasing risk overall. So those are the kind of the basic ideas behind these models that are going to be presented. However, most of the questions are pretty broad and open-ended because there's very little real data. So all of the models definitely have a tremendous amount of assumptions that they're making. So PrEP for key populations in low prevalence countries. This is in almost all low prevalence countries, MSM are the most affected population at risk for HIV. And so both of these models assume that PrEP will be used among MSM. And the model on the left is the cost effectiveness of PrEP for HIV prevention among MSM in the United Kingdom. And it basically shows some effect, but that effect can take a very long time. I know that these graphs are very small, but essentially the years go out to 2096. So yes, HIV incidence appears to reduce by 20 to 25%, but it takes a long time. The model on the right is cost effectiveness for PrEP among MSM in the Netherlands. And it's based on different levels of PrEP effectiveness, and all of them show that incidence does decrease. So there is an effect, but how much that effect will be is entirely related to how much effectiveness PrEP actually has when used in the population. And that's of course related to adherence. So can you eliminate HIV through a PrEP program? And basically what they came up with in this model is that yes, you can eventually reach an R0 of under 1. So R0 is just the concept of how many other infections you get from an initial infection. So an R0 of under 1 means that there won't be ongoing transmission, but it would take 80 years to get there. And it would decrease prevalence from 8% to 2% with no ongoing transmission, but it would take a tremendous amount of time to get there. So in terms of the impact on the epidemic, these are data from London clinics, and it does appear that HIV diagnosis has fallen since the introduction of PrEP. Increasing PrEP coverage has decreased HIV diagnosis among men of sex with men in London. The same thing has been seen in Sydney. And so this is pre-PrEP versus the PrEP era, and this was presented at CROI. So these are promising data, they're just preliminary. So one of the things that he went through was an analogy to giving hepatitis B vaccination. So hepatitis B vaccination in the Netherlands is specifically targeted to high-risk MSM. They've had free vaccination for 15 years and reached almost 60,000 MSM. And the annual number of notified acute HPV infections has decreased from more than 3,000 to less than 1,000 in 2016. So showing a tremendous improvement in incidence of HPV infection, and also improve the actual vaccination program. So targeting a high-risk group with this kind of prevention intervention can work. There are obvious differences between HPV vaccination and PrEP. PrEP is something that people at this point would have to take every day. That may change, but that's the current way that PrEP is being provided. Whereas HPV vaccination is, you have to get 3 doses and then you're done, and there's some protection after 1 dose. So it's a very different program, but potentially this shows that it could work. He also showed evidence from migrants from high prevalence countries. And these are 2 phylogenetic analyses showing that essentially the idea here is the chains of transmission that occur among MSM are much longer than the chains of transmission that occur among heterosexuals. So if you look at heterosexuals, usually their transmission chains are only 1 or 2 members long, but the MSM transmission chains can be of much larger lengths, up to 40 members. So definitely this is a group that really requires attention. And one of the points for the European context was that migrants from high prevalence countries, especially MSM, are in huge need of interventions. Then there are models in high prevalence countries. So before we're looking at low prevalence countries, really targeting key populations, these models are all in high prevalence countries. And some of it does have to do with targeting key populations as well, but we're mostly going to talk about coverage among general population. So in one modeling study of PrEP use in South Africa, the model assumption was that there would be 18% PrEP coverage among young women, and that this would result in a 1 to 7% of new HIV infections being averted by year. In a different study in KwaZulu-Natal, the impact of PrEP was found to be limited, and what would really be more useful are interventions that found early infection and provided treatment for those early infections. So the model on the left is the one with 18% coverage, and the model on the right is the study in KwaZulu-Natal. Another of his points was that we really need to figure out what the PrEP guidelines for professionals should be and the specific medical infrastructure needed for implementation and monitoring, and what needs to be evaluated. So we need to understand about effectiveness, which is related to coverage and adherence, and then monitoring of STIs, risk behavior, and resistance. So in conclusion of all of the current data that he was presenting, PrEP programs should target the groups at highest risk, and both high coverage and high adherence are essential. Whatever program is used for PrEP, it's extremely important to target the groups at higher risk. In low prevalence countries, this means targeting key populations. In high prevalence countries, PrEP can be useful in high incidence groups, but the overall impact seems to be limited so far, or at least with current evidence. PrEP does require good medical infrastructure, and national and regional monitoring are essential to evaluate the impact of PrEP for HIV incidence. In terms of PrEP needing good medical infrastructure, the next presentation actually conflicts with this idea a little bit, but that was his conclusion. So I'm just presenting it as is, but keep that in mind as we go through the next presentation. Before I move on, are there any questions about this one?
I think it was actually a very interesting presentation as well. I mean, and definitely we will continue. I mean, he has been involved in this. I mean, he was the director of the Amsterdam Health Clinic since the very beginning. He's a person with a very long history in HIV prevention and treatment. The thing is, perhaps his perspective is the perspective of a higher income country. That may explain a little bit his perspective around good medical infrastructure. Although I tend to agree with him in to a certain degree. What I would ask is whether or not he gets into the issue of event-driven PrEP versus daily PrEP, which is, I mean, that is an important issue in Europe, and also the issue of how to, I mean, if high risk is self-determined, or if there's any tool that can be used for that, and also high coverage, what high means in this case.
Okay, so he really doesn't define his terms very much in terms of high coverage and high risk. The next two presentations actually speak to those points a little bit more, although for the most part, most of what we've heard about event-driven versus daily PrEP is twofold. One, daily PrEP is just easier to remember, and two, event-driven PrEP, when it's been useful, has basically been daily PrEP at the level of 4 pills a week, which is sufficient, at least for men. So he did not address that in terms of modeling, but the next two presentations do speak to all of those different questions. Or at least they touch on them. Okay. So I'm going to move on to the next presentation. So this started out being 5 controversies around PrEP, but it really is, Dr. Becker increased it to 7. So the main question here is PrEP ready for wide deployment in 2018? And there's a list of countries that agree and a list of countries that are doing something. Peru is on here, but a lot of these countries, what they have are implementation studies, not government programs. And worldwide, it seems that there's an estimated 220,000 people on PrEP, mostly in the United States, and that doesn't include buyers clubs, which are estimated to be about 25,000 people globally. So more and more people want PrEP, and we definitely have evidence that PrEP works. So we're not going to go through that evidence again. I'm just going to talk through the 7 controversies that she brought up. The first is, does PrEP work for women in Africa? We all know the problems that occurred with the Partners PrEP study and the Voice study. And basically, the problem was that adherence was a huge problem in the Voice study and then increased. The Partners PrEP study did show better adherence, and when there's good adherence, there is a relative risk reduction that's associated with PrEP use. This is an overall meta-analysis, and there is a relative risk reduction, and basically the later studies show a greater reduction, and that's when people started using PrEP more, when there was better adherence. And the second part estimates the relative risk by subgroup, separating out the low adherence studies, the mixed adherence studies, and then the moderate high adherence studies. And definitely PrEP works if you take it. The issue is whether or not women in Africa want to take it. And her point was essentially that seems to be, the desire for PrEP seems to be increasing. And there are a lot of reasons why they think that women in the early studies were not able to take PrEP, but those reasons seem to be dissipating, at least. There is a difference between achieving a level of PrEP needed for prevention in rectal tissue versus in the female genital tract. And it does seem like, so in the Olay study on the left, HIV incidence was decreased with just 2 doses a week, although that was in a subgroup. In the partners PrEP, you really needed 7 doses a week for women. So there's a lot less forgiveness in terms of adherence for women than there is for men. So FemPrep and Voice had negative results, mostly due to adherence. Half of women never had PrEP detection in plasma. There are lots of reasons why they think that women could not take PrEP during these studies. Open label studies have worked much better, and the majority of women did actually use PrEP. There are still a lot of questions that should be answered about viral clade, tissue penetration in the vagina, STIs, issues of vaginal dysbiosis, and it does seem like there's a lot more data that needs to be collected, but oral PrEP does seem to work, and women do need to take it daily, whereas 4 times a week seems to work for rectal exposure. So the next part is that PrEP takes time to work. So this is the next controversy, and basically what she said was that there seem to be 2 schools of thought. One, that PrEP will work within 7 days, or after 7 days of taking PrEP, you will be protected, whereas the next school of thought, or the other school of thought, is that you really need 21 days for PrEP to work. And essentially, the problem is if you have something that's going to take 21 days for it to work, that's going to be much more problematic to actually implement. So she walked through a lot of evidence about how really probably the 7-day window is fine. And she walked through evidence from monkey models, from PEP, and then also from mother-to-child transmission. There definitely is a lot of evidence that once there's been HIV infection, there's very little time within which you can act to prevent actual acquisition of that infection. But it does, and it also seems that men don't need as long a lead-in period as women. So the graph on the right basically is just very similar information about number of tablets per week, and that there was good protection with 4 tablets per week among men, but that same has not been true among women. So this still seems to be a controversy, but having the evidence for 7 days is not bad. These slides are online, so anybody who's interested in this, I really summarized this part, but there's a lot of different kind of basic science evidence that she walks through for this point. So the next part is PrEP isn't safe during pregnancy. Now, these are all stated as controversies, so just take them that way. It's not necessarily that this is what should be said. So is PrEP really unsafe during pregnancy? And well, definitely what we know is that women who have HIV positive partners are at very increased risk of seroconversion among those who want to conceive. We also know that PrEP adherence is higher among pregnant women. There are studies that show PrEP exposed versus non-PrEP exposed and different pregnancy outcomes, preterm birth, pregnancy loss, and birth defects. And there isn't evidence that there's increased risk for PrEP users. again, more studies are needed, but it seems to be that it's not a safety issue for pregnancy. The next controversy is that PrEP does work for young people, but not as well, basically because of adherence. So especially in high prevalence settings, 15 to 24-year-olds are at very increased risk for HIV infection, and having PrEP for them would be useful. The evidence from the graph on the right is PrEP adherence in a clinical trial, and definitely, as you can see, the black line, which shows adherence in 18 to 21-year-olds, was much lower than the other two age groups. But in open label studies and implementation studies, adherence has been better. So hopefully that will be, as PrEP adherence has also improved in women, hopefully it also will improve among young people as these interventions move forward. This is data from the ADAPT study. So the two first rows are at 10 weeks and 30 weeks for age groups under 25, and anything over 40 in the last column means that there was a tablet taken in the last 24 hours. And the numbers at 10 weeks are higher for the group over the age of 25 at 100, but there's no statistical difference between the first row and the third row, or the second row and the fourth row. So hopefully in this open label study, adherence is better, and that will be the trend. There's more evidence of increasing adherence. This is from Project Prepare, and it was 300 HIV negative young MSM in the United States, and the majority did achieve protective drug levels during monthly visits, but then adherence dropped off when visits became every 3 months. So young people, it does seem like young people need more support to be adherent. And this is the same thing that's been seen in other studies. So this data are from a study that was conducted in Africa with young adults, and the adherence, which is in the quarterly visits towards the right, is much worse than the adherence that was seen in visits that were more close together. So that it doesn't necessarily mean that young adults have to come into the clinic, but something should be done to keep them engaged. And that might be social media groups or texting about adherence, but something should be done to keep them engaged and try to keep up their adherence levels. So the number 5 is PrEP is a medical intervention. And this is really where Linda Gale Becker was in disagreement with the presenter from the previous presentation. And what she said was, think about PrEP as a lifestyle choice. Do not medicalize this. This is what worked with condoms. So condoms, when they were presented as a medical device or a medical intervention, did not work very well. Condom social marketing has actually worked much better. And so the idea is that we should have PrEP social marketing. Make PrEP more accessible, make PrEP more mobile. What you need for PrEP are essentially HIV tests, we have rapid 4th generation HIV tests that can be used in mobile settings. They can be used. And then all of the other testing is pretty easy to collect and take back to a central lab. So there's no reason why PrEP cannot be offered in mobile settings. And then also to make PrEP interesting and fun. On the right are just some examples of PrEP advertisements for MSM and for young women. And those types of PrEP social marketing interventions should be promoted. Number 6 in the list of controversies was that PrEP causes STIs. Basically, that this was covered during the Schillinger presentation. Definitely, Linda Gale Becker was also in agreement that it seems that this is more linked to diagnostics and not as linked to actual increases in risk. There are some mixed data, but it mostly seems from systematic reviews that there's no evidence for increases in STIs among PrEP users. And PrEP has to include STI screening. It brings high-risk people into services and should be thought of this way. PrEP, again, as an overall sexual health intervention, not as a problematic increase in STIs. And one of the things that was also said was that, you know, if you implement PrEP, you should expect to see an increase in STIs because you are bringing in high-risk people for screening. So that just should be part and parcel of the beginning stages of a PrEP implementation. So the seventh controversy is that PrEP is too expensive. And so this is data from the UK and just shows a decrease in new HIV diagnoses after the introduction of PrEP in the United Kingdom. And then this is rollout of PrEP in South Africa, and basically they have universal ART and focused PrEP. And universal ART and general PrEP is probably unaffordable. But universal ART and focused PrEP focused on highest risk individuals, probably is affordable. And basically the main point was PrEP is not too expensive if the alternative is a lifetime of ARV treatment. So if this is the trade-off, then PrEP is definitely a bargain. So the issue there is the targeting of PrEP. PrEP has to be well targeted to high-risk groups so that that really is the trade-off and you're not giving PrEP to people who are at such low risk that you're essentially wasting this intervention. So in summary, 6 PrEP facts that Linda Gell-Becker presented. PrEP works in young women taken daily. PrEP works for safer conception. PrEP doesn't cause STIs, but STIs need attention. Time to protection from PrEP is likely 2 to 7 days. PrEP is the lifestyle, not a medication. And PrEP is cost effective when the cost of not using PrEP is HIV infection. Okay, so that's the end of Linda Gell-Becker's presentation. Any questions before I move on to the final presentation?
Well, probably move ahead because we don't have much time, Kalika. Go ahead.
Okay. Okay, so the next one is essentially just the information from a PrEP scale-up experience in Kenya. And decision-making should be informed in order to successfully scale up PrEP programs. So there are lots of topics that need to be taken into account and thought through: delivery models, pregnancy, cost effectiveness, breastfeeding, risk compensation, safety and efficacy, resistance, and willingness to use. So these are all, we've gone from RCTs to open label studies to demonstration projects, pilot delivery, and now wide scale implementation. And all of them, we have a lot of information from the RCTs and the earlier studies that can help answer questions around scale up. UNAIDS has called for 3 million people to be on PrEP by 2020. Right now, the target for 2017 is about 300,000. And again, we're at about 200,000 right now. So this was the scale-up framework for Kenya. And it included policymakers, demand creation, delivery considerations, money, monitoring, and evaluation. They had a very supportive landscape. The ART guidelines from 2016 included people on PrEP, so included PrEP for all people at risk of HIV. And in May 2017, Kenya launched the PrEP program in association with a strong baseline HIV testing program. And PrEP is just incorporated as part of a combination prevention strategy in the Kenya Ministry of Health. So some milestones for scale up. July 2016, the launch of the guidelines. October 2016, the creation of a technical working group. November 2016, they began implementation meetings and workshops on key lessons from demonstration projects. Then from November to April, meetings with the PrEP working group. And December 2016, generic tenofovir was approved for prevention. May 2017, the scale up of the national program was launched. So this is the coordination plan from the working group by the Ministry of Health. So they looked at commodities and supply chains, planning and coordination, research and cost modeling, monitoring and evaluation, and advocacy and communications. So really an overarching multidisciplinary considerations. The considerations for strategic delivery included who were the potential PrEP users, providers and policymakers, what's the age limit for PrEP provision, whether or not it's feasible, what are the preparing an end user communication plan and provider trainings, what will be the plan for monitoring of drug resistance, budgets, healthcare system capacity, what's the willingness to adapt to new prevention interventions, who can prescribe PrEP, and also community participation. In terms of background for Kenya, it's definitely a high prevalence country. There are prioritized populations, and the youth is only about 25% of the population, but account for the majority of incident HIV. And one of the things is that messages have to be differentiated according to the target population, but should always be positive. They used mostly social media campaigns and mainly written media, not television. So the campaign should match what is needed for the setting. Keep it simple. Simple forms to assess risk behaviors. They did not do creatinine and hepatitis B testing, and the need for the involvement of strategic partners to improve implementation. So far, PrEP uptake has been low from April 2017 to December 2017. They started with 1,000 people on PrEP, they're now at 1,100. However, the point here was that this matches what was seen in the United States. So if you look at the graph on the right, Kenya is essentially at the third quarter in 2013 for the United States. That's where they are right now. And PrEP didn't take off until really late 2014, 2015. So it takes some time for people to kind of get the word out and become used to having this different option. And that should be expected in scale-up programs. In terms of PrEP for the general population, there are different delivery facilities. So they did heart clinics, mostly for serodiscordant couples, sexual health clinics to reach women and adolescent girls and youth clinics, and mobile clinics. They have different delivery options as well, same-day initiation, self-testing programs, community platforms or community delivery for young women, PrEP champions, so people who will really go out and talk to kind of spread the word about PrEP, and WhatsApp groups. In terms of PrEP for key populations, they have same-day delivery drop-in centers, public health facilities, and also private health facilities. There are considerations to make PrEP delivery doable. One is for it to be nurse-led, so not having the requirement of having a doctor involved for prescription. Also, integrated and comprehensive services to maximize the impact beyond PrEP, so use standard testing protocols, and not having too much fuss about adherence and retention. People can move in and out of PrEP, and that's okay. Also, in terms of selecting PrEP eligibility, potentially it's useful, but mostly the utility is to screen people in, not to screen people out, and let people be self-select for risk. So the bottom line is people who turn up and ask for PrEP are probably those who need PrEP and would benefit from it. Lessons learned from implementation: leadership is vital. It's vital also to have harmonious messages between everybody and one clear message, and education for healthcare providers to have them be willing to recommend and prescribe, identify champions within facilities, and to have continuing education are all important, especially because of personnel turnover and knowledge decay. Also, you shouldn't be discouraged by low initial uptake. Community education influences how many people come in, and it takes time for communities to accept new interventions. And there's also a need to employ strategies to mitigate stigma and to be proactive in terms of community and media engagement. So in summary, PrEP scale-up has led to PrEP uptake, and continuous community education should include monitoring of myths and misconceptions. Myths and misconceptions do occur, and they should be responded to. And it's also important to provide different delivery options and different messages for different populations. And combination prevention, including PrEP, has been demonstrated to have an effect, such as in San Francisco and Australia. Whether or not it has an effect in this setting remains to be seen, but the lessons from their implementation are important. There are a lot of unanswered questions, such as how to motivate and measure adherence and effective PrEP use, understanding the preferences of adolescent girls and young women, integrating PrEP into routine care and services, especially in terms of reproductive health, and measuring the population level impact. So PrEP has catalyzed advocacy for HIV prevention services and re-energized provision of combination prevention. So for women, PrEP is controlled and discreet, and it adds protection for sex workers. For MSM, many have been inspired by having a new prevention choice. For HIV serodiscordant couples, it's a way for them to share responsibility for prevention and also to achieve safer conception. For the general population, PrEP can lead to increased HIV testing, identification of people living with HIV, and linkage to ART, and also to hepatitis B vaccination. And for peers and lay people, there are issues of empowerment beyond PrEP itself. It can help just to spread the word about PrEP and having this new HIV prevention technology. So that is the final content slide. Does anybody have any questions about this presentation?
I actually have a comment. I mean, all presentations have been very, very good. This one as well is very interesting in the sense that it, more than the others, shows how the issue of adherence and retention is very much something that comes from clinical trials that loses meaning in scaling up, because I mean we're not talking about people having to be retained by force, doing as much as we can to keep them there. I mean, here the goal is not to complete the trial. The goal is here. The goal is to help, I mean, people prevent HIV, and so I mean that has to be taken into account at all times. So if it's not working for people, I mean, there should be a way to, I mean, agree with people that I mean, at some point it's clearly not working. I mean, people don't like it, they can't use it. So I mean, why sort of maintain that and talk about low adherence? So I think the establishing somebody in PrEP is something that needs to be better sort of or more discussed, because I mean, so the idea of people getting in and out and not making a big fuss out of that is very interesting, and probably we need to to continue to discuss that set of concepts from now on.
Yeah, and I think it's also important to keep in mind the issues of there will be increased STI diagnoses at the beginning of PrEP. You will have issues of slow startup. And all of those are things that governments should keep in mind, because it's not going to be like you flip the switch, provide PrEP, and everything will be better. It won't work that way. So, all of the different interdisciplinary issues that need to be dealt with to provide PrEP will lead, can lead to good scale up, but it will take a while. And so it will probably take a while to see any effect in terms of cost effectiveness or the prevention of HIV incidence. And that's something that should be expected.
Mm-hmm. Exactly. I think this is fascinating. I think this is showing how, an intervention that is, in theory, looking at something very specific, in the end, sort of redefines, to a much broader extent, the way we look at HIV prevention, because it sort of it changes the frame, the bigger framework. So it's really interesting. Anyway, I think our time is finished, and we'll stay here. Oh, I see. You have the.
I just wanted to put this slide up because it does have. So the beginning part is just the overall portal for CROI webcasts, and there are tons of presentations that are available, and then the specific links for each of the presentations that we've summarized here.
Excellent, excellent. Thank you very much. This was an excellent summary. So this was in English. It's going to be uploaded to our website and our YouTube channel soon. And tomorrow we have a Spanish language session at the same time. Marcos is asking if we can share the presentation. Yeah, we can share it, definitely. Okay, so thank you very much. Thank you, Kelika and Juan Vicente, for preparing the summary, and we'll see each other tomorrow for those of you who are participating in the Spanish language session. Okay, thank you. Bye.
Okay, thank you very much. Bye-bye.
Thank you. Bye.